Thank you for having me. So I'm going to present a case today, but I'm going to give you your take-home points before you hear the case. Acute and chronic pain are different diseases, and thus we need to have different approaches to how we diagnose them and how we treat them. Those are going to be your take-home points. All right. Any questions? All right, here we go. Sue, 44-year-old female with Crohn's disease for 4 years. Over past 6 months, she is identifying a new abdominal pain that is getting worse. She has a mild increase in pain with eating, 2 to 3 loose bowel movements per day, no change in pain with defecation. This new bout of what she's now describing as constant pain started after a C. diff infection 3 months ago. This was treated with an antibiotic and cleared the C. diff infection. Her only other ongoing medications is an anti-TNF. Take your choice which one. And she's had no surgeries. So let's talk about acute versus chronic pain. By the International Association of Pain Society, and really this is something that is endorsed in the world across pain societies, acute pain lasts less than 3 months. The cause is usually understood and often is the direct result of disease or surgery, and it is curative for the most part. Chronic pain, anything that is constant for 3 months or longer, or intermittent for 6 months, is considered constant pain, chronic pain, and it can be linked to a physiological effect or a physiological trigger, often though there is no clear association. And really the important thing about chronic pain is the treatment is goal-oriented and often non-curative. And as I go through specific treatments that have empirical evidence, and I try to focus on what we do and the empirical evidence to support that, it is so important as a treater and then for your patients that you do send the message if they have chronic pain that we want to help you have a higher quality of life, we want to get you as functional as possible, we want to reduce the pain distress, but we may or may not be able to eliminate the actual pain signal. So we heard a little bit from Dr. Higgins about measuring things and patient-reported instruments and outcomes. So often, most of us in our clinics use some kind of visual analog scale. So we ask patients if they're having current pain and the severity on some kind of scale. However, what's being increasingly known in pain centers is that we need to measure much more than just severity. We really need to know about how much pain interferes, so the amount of disability in the patient's life, and we have to know about pain behavior. So pain behavior, and this is from the PROMIS instruments, and IMH has spent a lot of time developing a lot of psychosocial measures, including pain, and you had the web link on the previous slide. Pain behaviors really are linked to the degree of suffering, emotional, subjective response to the pain. And it's being increasingly recognized that this is where the ball has to be in terms of our diagnosing and treating pain if the pain is chronic. So if we talk about Sue just with what we know about her to this point, and we're thinking about acute versus acute chronic pain, we might be thinking about some kind of gastroenteritis, so the pain still being there from her C. diff infection. Is she having an IBD flare? We know from the literature that pain is worse in Crohn's disease than ulcerative colitis patients, though it can happen in either. Now, she did not have surgery, but obviously acute pain can happen after an abdominal surgery. Acute chronic is a combination of IBD, IBS, so relatively inactive IBD as best as we can tell by our objective measures, and yet an ongoing functional pain that in the field has been called IBD, IBS. Rome 3 criteria for IBS. which you all probably know is pretty subjective in many ways. Abdominal pain at least 3 days a month for at least 3 months, and accompanied by 2 of the following. The pain is relieved by defecation. The pain is associated with altered stool frequency or altered stool consistency. So let's talk about acute versus chronic pain. So acute pain, we can think in our IBD patients as related to inflammation. In Crohn's disease, the inflammation can go through all the layers of the mucosa, and hence there's a larger risk of nerve endings being exposed, and so directly being affected by pain. Nitric oxide has been one mechanism by which the nerve endings get literally pestered, and it is painful. Obviously, there's anatomical sources of pain. There's motility sources of pain, post-surgical recovery, bacterial overgrowth. Now, that can happen with our patients who have pouches. Something that is being increasingly recognized is how much the menstrual cycle can affect pain state, and so it's very important to ask in your history with the patient, a female who has new onset pain, where they are in their menstrual cycle. Pain is worse right before menses and during menses. And then there was some question in your literature about whether anti-TNFs cause pain, and really the definitive studies that are out there and some meta-analyses looking at anti-TNF agents, they do not cause pain, so there's no association causally. They do cause fatigue. Patients who are fatigued are more sensitive to pain from other sources. Now, chronic pain. So once pain goes chronic, there's central nervous system involvement. So you need to think about what is happening in the brain. There is often a psychological overlay of anxiety and depression. There's still neurobiological factors, visceral hyperalgesia. More and more studies that when you have true visceral hyperalgesia, there's also changes at the level of spinal cord. And I'm going to get back to this when I talk about the medications we use to target pain and why that's important. And then growing work in the area of the microbiome, not just affecting the brain in terms of pain, but also anxiety and depression. So if you have acute pain, we identify the source, we treat it. For the most part, patients get better. Not so for chronic pain. So on with the case. Surprise, surprise, her CRP is normal, her colonoscopy is negative for active disease. So now we're thinking about more moving in the direction of an IBD-IBS pain syndrome, again, possibly from the C. diff exposure. And she's stopped going to work, she's stopped being social, and so now we are getting pain disability added to her experiencing the pain itself. So what do we know about IBD-IBS? So depending on the study, 30 to 80% of adults with inactive IBD can have IBS-like symptoms. We have to still recognize that there might be some kind of microscopic or subsyndromal inflammation in these cases, but we're certainly not picking it up with the testing that we currently have available. These patients have very high rates of anxiety and depression, and an increased appreciation how much early life trauma can be linked to visceral hypersensitivity. Now, this is highly female in the literature. I think it's because we probe this more in females and males, but I certainly have seen cases in males too where trauma was linked to visceral hypersensitivity. And we all think of sexual trauma, first 5 years of life, any kind of chronic or extreme childhood adversity in the first 5 years of life can affect how we interpret what's happening in our bodies into adulthood. You heard this morning from Dr. Higgins about increased TRPV1, so the TRPV vanilloid family of proteins, and sure enough, this has also been shown in patients with IBD-IBS. So what's out there with empirical support for pain in IBS. So I'm going to step away from IBS, IBD for a minute because it's really the same for our patients. So this is what is out there for IBS. Psychosocial interventions, cognitive behavioral therapy, scripted hypnotherapy are still the most supported methods out there for helping patients both reduce pain and, more importantly, improve quality of life and decrease pain-associated distress. These are 8 to 12 sessions given approximately over a 3-month period and with 70% response rate in 70% of patients. So very effective. You have to find trained behavioral specialists to provide these in your areas, but again, number one treatment. Diet, low FODMAP diet, there was a meta-analysis showing that this could actually specifically help patients with pain. Good luck getting patients to stick with this diet, but those that are motivated and do stick with them do have a positive effect. All right. In terms of pain medications in IBS, so the antidepressants still have moderate evidence, and I'll cover those when I cover them for IBD. IBS, rifaximin has some support for IBS, that is the diarrhea subtype. We don't know yet for IBD. I can tell you at Pittsburgh, this is used quite frequently, but again, in the literature, we don't have support. Now, we also have agents available for IBS constipation. These do relieve pain in that population, but in our IBD population, they're contraindicated if you look at the FDA guidelines for any mechanical source of pain, and certainly they can be a setup for intestinal obstruction, worsening that. So they are not currently recommended for our IBD patients. So onwards with Sue. We tell her that we're going to teach her some behavioral interventions for pain management, so distraction techniques and hypnosis, so the brain can be less reactive to the false alarm pain signals. So this is language that we typically use with these patients. She mentioned that currently she is having impaired sleep, which can be common with patients in pain. So we're going to teach her some behavioral sleep interventions and sleep hygiene. Sleep is such a low-hanging fruit for all of you to target. And this is something that you can teach your nurses to give some behavioral techniques, learn about sleep hygiene, and poor sleep is just bad for the body, bad for the brain, including the processing of pain. And not unlike many of our patients, even though we have moderate efficacy for our antidepressants, I don't want to be in an antidepressant. This is not mental. So common reaction. And good for Sue because actually we really want to try the behavioral interventions before we expose her to yet another drug. So what are the things that we address about poor sleep? Sleep regularity, their subjective satisfaction with sleep, the timing of sleep, so does it sync with the diurnal light-dark cycle? Is it adequate duration? We all need, everybody in this room is supposed to be getting 7 to 8 hours of sleep a night. Those are the new guidelines that just came out. Anything less is increasing all of our risk to exaggerated stress responses and chronic disease down the road. For our patients, 8 to 9 hours. High efficiency sleep. So efficiency is time in bed equals time asleep minus 30 minutes. And then how alert our patients are during the day. So these are the things that we can target with behavioral interventions. You have this in your slides. I'm not going to spend time on it now, but I think it is important that there are some very simple things that we can tell our patients to do that have proven efficacy in improving their sleep. And most of them have to do with not going to bed until you're tired and sleeping in bed. And getting out of bed if you're not sleeping so that you don't start associating your bed with worrying about not sleeping. And daytime activity, exercise during the day, and low stimulating activities before you fall asleep at night, so within the 2 hours of bedtime. You shouldn't be playing your high-amp video game. You shouldn't be doing your intensive exercise. You should be settling for sleep. What is sleep? Sleep is turning off our brains. So anything that keeps our brains on is bad for sleep induction. So let's go on with Sue. Surprise, surprise, she's non-compliant with her psychosocial interventions, and that's really the most challenging thing with our patients, is talking them into trying these things. The number one most important ingredient for that, invested gastroenterologists. So the GI docs at University of Pittsburgh have been brainwashed. I worked hard to achieve this, but they have been brainwashed to really sell behavioral interventions as a part of comprehensive IBD care. And something about it coming from your IBD doc makes patients more willing to try it. Now, Sue has a history of recurrent depression, so she really did not emphasize that, and often it's only with time and investment in our patients that we learn really about their psychosocial histories. She has other pain syndromes. She has fibromyalgia. She has chronic headaches, but no other medical diagnoses. She went to the ER a month ago. She got opiates. She likes the opiates. She now wants to continue her opiates, even though, interestingly, they had a slight improvement in pain. Initially, they were great, and even a month out, they're not really having an effect, but she still wants them because she remembers that initial effect that she had with them. She's fighting with ER docs, and currently, as we're talking to her now, 6 months later, she's depressed and still not sleeping. So now we're moving into chronic pain and suffering. So there is a syndrome called chronic pain syndrome that is being increasingly recognized across different chronic pains. It's a central nervous system disturbance, so it's how our brain centers which process the pain signal, higher limbic and cortical centers, are actually being altered. So our brain is a neuroplastic organ, and so these centers get altered so that they get more and more susceptible to receiving and amplifying pain signals from the periphery, or taking a normal signal and amplifying it into something abnormal. So when you have chronic pain syndromes, behavioral factors are prominent, so you often have anxiety and depression, more common in females. There is a genetic predisposition, so ask for family history. Early trauma and abuse is key. So that's really becoming an increasing theme in chronic pain. Ask about early life. You have to develop a relationship with patients to have them give you that information. So what's thought to happen with chronic pain is there's a repetitive exposure to stressors that starts early that leads to psychological and behavioral responses. Emotional pain and physical pain processing get literally mixed up in the brain, and this leads to vicious cycles. So now we're moving Sue into the category of possibly not just IBD-IBS, but central pain. She has multiple pain syndromes. She still has an endorsed childhood trauma, but she does have psychopathology. Now she's moved to narcotic use, so she's really become a chronic, complex patient quickly. So chronic central pain does not respond to narcotics or brief cognitive behavioral therapy. So we really need to change the lens through which we see the treatment of chronic pain. Starts with education. So I have these diagrams that I give out to all of my patients talking about how important the brain is, that their psychological state of mind and those brain centers that are processing the pain are as important to treat as whatever the GI docs are doing on the physical IBD side. Now, one central pain type that we come across, and you all come across, in about 5 to 10% of your patients who have chronic pain is borderline personality disorder, characterized by pervasive, persistent patterns of instability and impulsivity. So these are instability in mood, black and white. They're either happy or they're angry or sad. Their self-image, their relationships, and disruption in emotional, cognitive, interpersonal domains, both behaviorally and at the level of when we image their brains. So it's out there, and why this is important to identify is you need a psychotherapist to help you manage these patients. Or not only do they really make your life stressful, but they will not get better. With appropriate psychotherapy, long-term psychotherapy, these patients can really have a significant reduction in at least the distress their pain causes them. Borderline personality patients have very high rates of chronic pain syndromes. They are known to use narcotics excessively, and there has been an association published and documented in IBD between narcotic use and borderline personality disorder, Crowell, 2009. So Sue does have many characteristics of central pain, and we are going to continue to assess her for early trauma, but it really does not matter if we can't uncover it because we're going to treat her for these central pain components. And we also now have to assess if her narcotic use has evolved into substance abuse or dependence. So for chronic pain, behavioral management is key. Clear explanation of expectations, empathic listening, setting consistent limits with these patients, clear verbal and written instructions, validate their anger. These are often angry patients, but redirect their helplessness and hopelessness away from their treater and getting them to join you in engaging in what we can do. Rechannel entitlement into their realistic expectation of getting good care, just like you provide for any other patient. And one of the most effective things you can do is to have regularly scheduled appointments for these patients, not based on worsening of their symptoms. So bring them in for that 5-minute check with your nurses, 5-minute check-in with you, does a lot to prevent them from ramping up their behaviors. Behavior interventions for chronic pain, meditation, mindfulness techniques have the most support, hypnosis, and has a growing neurobiological evidence base, and moderate exercise. Because once you add disability, physical disability to chronic pain, you're adding a whole other layer to the onion that makes the pain worse. So for Sue, we're going to build a strong therapeutic relationship. We're going to continue to offer her the behavioral interventions, and we're going to engage her. We've developed a relationship now. Now we've been working together for about 9 months, and so she trusts us more, and she's willing to consider non-opioid medications. And we're going to explore her willingness to come off the opioids. What are the non-opioid pharmacological interventions for Sue? So SSRIs across the board help with comorbid anxiety and depression, which can relieve the suffering. There really is no good evidence that they target the pain directly. Our best evidence in the field, if we're going on our literature, is tricyclic antidepressants. Starting low, going slow, treating to side effect, or I should say treating to pain relief or side effect intolerability. And it's so important to tell our patients with all of our antidepressants that the side effects happen first. The pain relief could take 3 to 4 weeks before we get there. And again, our tricyclics can be more or less sedating. So again, depending on how much sleep is a problem, you could pick the agent accordingly. There's other sort of cost-benefit profiles we consider in terms of their adverse effects, in terms of how much comorbid depression and anxiety there is. The SNRIs do very well with pain and depression. Duloxetine is probably the most studied one. And with the SSRIs and SNRI, their suicide overdose risk is minimal. With tricyclics at high doses, they can be lethal. Mechanistic approach to pain. So we don't have time to really dig into this slide in detail other than to tell you that the field of psychiatry, the field of neuroscience, is really aggressively looking at where in the body, at the level of the brain, the level of the spinal cord, the level of the peripheral nervous system, are different psychotropic agents act. And what's important here is this is probably the second most common diagram that I show my patients, to show them that even though I'm a psychiatrist, even though we're using psychotropic medications, they have just as much physiological basis as their IBD medications that they're taking for the inflammation. These are some of the FDA-approved treatments for neuropathic chronic pain, and all of these, you start at a dose, you start at a pediatric dose if you're looking for the indication, and you go up extremely slowly, and They can be effective, but the key is that none of these are a quick fix. And you have in the parentheses there the neuropathic chronic pain syndrome for which they receive their indication. Milnacipran is an SNRI that is an SNRI but only has an indication for fibromyalgia, not for anxiety and depression. So you can truly tell your patients that that one is not an antidepressant. I gave you some of the mood stabilizers that have randomized control trial support and gave you some dosing recommendations, oxycarbazepine, lamotrigine, and topiramate. And again, these help at both the level of the peripheral nerve as well as can help at the level of the brain to tone down that chronic pain. The concern with opioids, there's no evidence that they work in a randomized controlled trial for chronic abdominal pain, and they're riddled with problems: psychological, physical dependence, high rates of infection mortality, and patients can develop tolerance, and in about 6 to 7%, they can have a visceral hyperalgesia called narcotic bowel syndrome. So really, if we have to use them acutely, but once it's going longer than 2 to 4 weeks, it has the potential for escalating into a problem. Our patients use opioids. So 5 to 21% of patients with IBD are on chronic narcotic in an outpatient setting and 20 to 70% on an inpatient setting. And there are risk factors for which of our patients could turn into chronic users: substance abuse history, psychiatric history, if they have a history of IBS trauma, and females. So we want to attempt opioid detoxification for Sue. And we have developed a relationship, so we're going to attempt an outpatient taper. But if she can't tolerate a slow taper, then Dr. Drossman and his group at UNC developed a rapid detoxification protocol where you have 10 to 33% of the IV equivalent dose of morphine that they're on, reduce it by that much, the 10 to 33% in an inpatient setting. You treat them for anxiety while they're there, you treat them for withdrawal symptoms, and you continue your behavioral interventions. And when done in this way, they actually had over 50% of their patients have a significant reduction in their pain scores. However, they did not offer these patients follow-up, behavioral follow-up, and without the follow-up, very high rates of recidivism. So if you're doing this, you need to be partnered with a behavioral specialist who is available to have ongoing treatment behaviorally for these patients. If you are going to prescribe, it's so important that you have a risk management plan. Know your state's rules and regulations, do the random toxicology, have a contract, and if your patient violates the contract, no opioids. So this cannot be negotiable. Many doctors are getting in serious legal trouble, especially since there is a national push to stop the narcotic epidemic that's in our country. So in ending then, we want to have a rational approach to chronic pain. In addition to our behavioral interventions, we want to titrate one medication at a time, start at the lowest dose, slowly titrate, and continue that medication only if it works. If it doesn't work, move to something else, and polypharmacy with our psychotropics only if you had a true objective partial response to an agent you're using. So in ending then, there is not a one-size-fits-all to treating pain with IBD. I like to start with active IBD versus inactive IBD. I like to then think of, is this acute pain or chronic pain? If it's acute pain, often behavioral services aren't used or needed. And if it's chronic pain, again, we keep our eye on the person, their specific root cause of their pain, their background, and we develop individualized plans that we really reinvestigate every 3 to 6 months, reassess, reformulate to make sure that they're getting better. Thank you.